Okay. Lacrimal gland is situated. Main lacrimal gland is situated superior-temporally in the orbit above the globe. Okay. And tears are secreted by main lacrimal gland and accessory lacrimal glands like gland of Wolfram and Cross. So these secreted tears will get collected at the medial canthus in a shape of lake. It is also known as lacus lacrimalis. As you all know, on the medial end of the upper lid and lower lid, you will have a puncta. When you revert your lid and see in the mirror, you can see a small opening which is known as lacrimal puncta. Here at the medial end of the upper lid and lower lid, you can see a small puncta. This puncta will open into canaliculus. First 1 millimeter of canaliculus will be vertical and then 7 millimeter will run medially. Similarly, in the lower lid, 1 millimeter will be vertical and then 7 millimeter it will run medially, horizontally and enter into lacrimal sac. This is the lacrimal sac. And lacrimal sac ends into nasolacrimal duct which opens into inferior meatus. Okay. So tears are secreted by main lacrimal gland which is situated superiotemporally and gland of Cross and Wolfram which is present in the superior fornix and inferior fornix of conjunctiva. They flow, cover the cornea and comes and form the lacus lacrimalis medially. Again, you remember the anatomy of the orbicularis oculi. Orbicularis oculi muscle is the muscle which closes the lids and it gets inserted into medial canthal tendon. Medial canthal tendon will have two limbs, anterior limb and posterior limb. And this lacrimal sac will be sandwiched between anterior limb and posterior limb of medial canthal tendon, and medial canthal tendon will be inserted into lacrimal crest of the lacrimal bone. So whenever patient blinks, there will be negative pressure will be created on the lacrimal sac. So whenever a negative pressure is created on a hollow structure, so you might have seen in your nephew and niece antibiotic or B complex bottle, the paper will be provided. So whenever you press on the paper and dip it into the drug will get raised into the column and you will put the drops into the mouth of your nephew or niece. The same mechanism happens here. Whenever we blink, there will be negative pressure will be created in the lacrimal sac, and when negative pressure is created, this puncta will dip into the lacus lacrimalis, and by negative pressure, the tears will get sucked into the lacrimal canaliculi and comes into the sac. And with second blink, it will goes down with the gravity into the nasolacrimal duct and comes into the nose. This is the normal flow of the tears. They are formed by the main lacrimal gland and accessory lacrimal glands, collected at the lacus lacrimalis, and by the negative pressure which is created by the pressure on the sac by contraction of the orbicularis muscle, it gets sucked into the canaliculus and comes into the sac and gets drained into the nose through inferior meatus. This is the normal flow of the tears. So you pictorially, the tears which get collected in lacus lacrimalis by the blink. Whenever patient blinks, it will get sucked by the negative pressure into the sac, and by the gravity, it comes down into the nasolacrimal duct and gets drained into the nose through opening into the inferior meatus of the nose. So embryology Embryology begins at weeks of gestation along the line of maxillary and lateral nasal processes. Ectodermal fold extends into underlying mesenchyme and forms solid rods of cell between medial canthus and nasal cavity. So whenever a hollow structure is formed, if you remember the anatomy which you have read in the first year, it extends in the form of cord of the cells, and then later on then canalization of that cord will occur. So the canalization of the ectodermal cord begins at 3 months at medial canthus. Canalization progresses towards eyelid margin and inferior meatus. Communication of the lacrimal drainage system and nose occurs at 6th month intragestational period. Lacrimal puncta opens into the lid margin at the end of 7th month when the lids separate. Two lids will separate at the 7th month of intrauterine gestation. Tear duct opening into the inferior meatus get canalized at or after the birth. This you should remember to understand the pathology of congenital Dacryocystitis. So canalization occurs at 3rd month. Canalization progresses at the eyelid margin and inferior meatus, and then puncta will form at 7th month, and tear duct opening into the inferior meatus get canalized at birth or after birth. So one pathology is congenital nasal lacrimal duct obstruction. What are the causes? Presence of membrane at the wall of Hasner in the nasal cavity at NLD. There is a present at the
హలో
Hasner.
మమ్మీ లేదు, ఆంటీ వాళ్ళ ఇంటికి పోయింది.
Please switch off
ఆంటీ
your
వాళ్ళ
phone.
ఇంటికి పోయింది.
Please switch off your phones. Presence of membrane at the wall of Hasner in the nasal cavity at NLD opening is the one cause. Congenital atresia of the NLD. As I told you, NLD lacrimal system starts as a cord, cell cords, and canalization will occur. If canalization doesn't occur, it is known as atresia. So congenital atresia of the NLD is another cause for nasolacrimal duct obstruction. Sometimes congenital mucosal of the sac will occur. Atresia of the canalicula or puncta can occur. Cleft anomalies of the face. You might have read, as I told you, the lacrimal system between the lateral process and the medial process. So if the processes of the branchial process of the face doesn't join, it will lead to cleft lip and cleft palate. So cleft lip and cleft palate anomalies can also lead to nasolacrimal duct obstruction. So what are the signs of congenital nasolacrimal duct obstruction? Epiphora. There will be watering. So the difference between discharge and epiphora is excessive when the normal amount of lacrimal secretion which cannot be drained normally, it comes out. It is known as epiphora. So this happens when reflex lacrimation occurs. Whenever you cut the onion or there is some irritant enters into the eye, you will have watery discharge from the eye or excessive lacrimation. It is known as epiphora. You should differentiate it with the discharge. Discharge is a pathological secretion. So the matting of the cells, lashes on the medial part of the lids will be there. Mucus discharge from the mucosal will be there. Periocular excoriation of the skin is there. Whenever a thing which is to be drained, if it gets obstructed, the local bacteria, commensals, the naturally present bacteria in the conjunctival sac will become potential pathogen. You might have read in microbiology. Every hole in the body will have natural flora, and this natural flora will become potential pathogen if there is obstruction or immunity of the patient is low. So when there is obstruction to the nasolacrimal duct, the normal conjunctival flora will become potential pathogen, and it will infect the lacrimal secretion. And as you know, Staphylococcus and streptococci will release enzymes. So this in the discharge will have the enzymes which will excoriate the skin. And signs of acute and chronic dacryocystitis can also occur whenever there is obstruction. How will you manage nasolacrimal duct obstruction? Krigler's massage. So you have to put the finger. You should teach the mother to put the finger at the medial canthus of the child and then put the pressure on the lacrimal sac area and massage it from above downwards, from up to down. 3 sittings per day she has to do, 10 to 20 strokes per sitting. In the morning, 10 to 20 strokes, afternoon, 10 to 20 strokes, and night, 10 to 20 strokes. Considerable pressure has to be put on lacrimal sac area, and after doing the massage, she should in, instill the antibiotic drops. So if the parents do it or mother does the Krigler's massage normally, 99% of the children, the opening, the flimsy membranes which are present within the nasolacrimal duct will break and the flow of the tears will be restored. Nasolacrimal duct will become patent and child doesn't require any surgical intervention. If the parents doesn't do Krigler's massage as instructed by us, then within first birthday of the child, you have to do probing and other methods of opening the obstructed nasolacrimal duct is balloon dacryoplasty. If the obstruction is strong, then you have to resort to dacryocystostomy or rhinostomy. So this is how the probing will be done. Under general anesthesia, you have to dilate the punctum of the child, lacrimal padavi needle-ship punctum dilator, and then introduce the Bowman's probe like this, and then pass it into the nasolacrimal duct as it is shown in the figure B. You dilate the puncta, you introduce the needle-ship Bowman's probe up to here and then straighten it and then pass it into the nasolacrimal duct till it comes into the nose. So you will breaking the flimsy adhesions or membranes which are present within the nasolacrimal duct congenitally. This is the live patient in which the probing is being done. There's a line diagram which I had shown you. Now coming to the adult acute dacryocystitis. How acute dacryocystitis occur? Infection of the lacrimal sac. It is acute exacerbation of the chronic dacryocystitis or peridacryocystitis. Causative agents are again, as I told you, streptococcus, staphylococcus, pneumococcus, H. influenza, which are all commensals in the conjunctival sac. Whenever there is obstruction, this commensals will become potential pathogen and infect the patient. And other reason for infection is if the patient is diabetic or if patient is immunocompromised, then acute dacryocystitis will occur. So acute dacryocystitis will have three stages. Stage of cellulitis. This we have discussed in detail while discussing the infections of the orbit. Preseptal cellulitis. When the infection of the sac or any adnexa occurs, it will present as preseptal cellulitis. Preseptal means the infection has not entered the orbit, it has remitted to the lids only. So it will present as lydedema, redness and tenderness. General features will be there like high grade fever and toxicity in the patient. The second stage, if you don't treat preseptal cellulitis, it will become lacrimal abscess. Swelling will get organized and fluctuant swelling with all signs of inflammation will be present at the medial canthus. First will point out if you don't drain it surgically, the abscess will try to burst on its own. So if the third stage is stage of fistula formation. When abscess bursts on its own, sometimes the opening will get epithelialized. So this is the opening. So the proximity will be there. If you remember the anatomy, the sac will lie here, and when abscess it bursts, the sac and epithelium and skin will get lined by the opening through which the abscess has burned, and fistula will form. So lacrimal fluid and mucoid discharge will come out whenever you press the lacrimal sac area from this opening. which is the fistulous opening because of the by bursting of the abscess which has formed. Fistula, by definition, all of you might know, it is a communication between the two epithelium, and the communication channel will also have epithelial or endothelial lining. So how are you going to treat the cellulitic stage? This I had taken in detail while dealing with preseptal cellulitis and inflammation of the orbit. Heart fomentation, intravenous antibiotics like injection cefotaxime 1 gram IVBD or injection augmentin 625 milligram intravenously TID you can give with the NSAID tablets 3 times a day and Serratiopeptidase 50 days to reduce the inflammation. Treatment of the abscess stage, incision and drain. Wherever there is collection of the pus in the body, you should incise and drain it by a clean surgical incision. If you don't drain it, if it bursts on its own, then it will end up in fistula stage. To drain it with big incision, continue IV antibiotic and do daily aseptic dressing till scar tissue forms. Treatment of fistula stage, you have to do dacryocystitis with fistulectomy. If the patient is very old, you cannot withstand DCR surgery, then you can do dacryocystectomy. Remove the sac with fistulectomy. What are the complications of acute dacryocystitis? Acute conjunctivitis can occur because medial part of the conjunctiva is in connection with the sac. Infected secretion from the sac will come out into the conjunctiva, bulbar conjunctiva, medially, and patient can have acute conjunctivitis. Normally, we'll have, whenever we go out, we'll have minute abrasions on the cornea which get heals. If there is a lurking infection there in the sac, the abrasion of the cornea get converted into ulcer cornea. So, the complication of the acute dacryocystitis is ulcer cornea. Preseptal cellulitis can occur. If you don't treat preseptal cellulitis properly, it can enter into the orbit through septum orbital and get converted into orbital cellulitis. And then if the infection spreads onto the cheek and face, it becomes facial cellulitis. If the infection enters into the bone, lacrimal bone, the patient can have osteomyelitis of the lacrimal bone. And if infection enters through the venous drainage channel into the brain, into the cavernous sinus, patient can have life-threatening complication like cavernous sinus thrombosis. The next disease is chronic dacryocystitis, obstruction of the nasolacrimal duct leading to stasis and infection. It is commonly seen in patients above 45 years of age. Females are more prone because the nasolacrimal duct will be long in that and bony ostium will be small. And as the female approaches perimenopausal age, the secretions will get dried up, and like any other secretions, the nasolacrimal duct will also get fibrosed, and females are more prone for chronic dacryocystitis. Any trauma to the nasal bone during a fight, whenever somebody hits on the nasal bone, there will be fracture of the nasolacrimal canal through which the nasolacrimal duct passes. So it can get severe. In road traffic accident also, in the fracture of the nasal bone, nasolacrimal canal can get fractured and there can be severing of the NLD. Obstruction of the lower end of the NLD due to nasal pathologies like polyps in the nose or fungal granuloma in the nose or deviated nasal septum can also lead to chronic dacryocystitis. What are the signs and symptoms? Watering. And whenever you put pressure on the lacrimal sac area, mucopurulent discharge will come out from the lacrimal puncta. And you can do lacrimal test which will be negative and lacrimal syringing will be negative. So this is regurgitation test. Whenever you put pressure on the lacrimal sac area, you can see how the pus comes out from the upper and lower puncta. Mucopurulent discharge coming out from the upper and lower puncta. lacrimal test. Lacrimal test is a simple test, as I told you, the flow of how tear flows. So we will take the advantage of the flow of the tears. Just put a drop of any dye into the lower fornix so that will stain the tears and ask the patient to blink the eyelids. So the colored or the tears which are stained by the dye which we have will enter into the lacrimal sac and then you whitewash the excess dye in the eye and then give a clean cotton to the patient. Put a earbud into the nose of the patient and ask the patient to sneeze. You can see the stain on the cotton or the earbud coming through the nose, then lacrimal test is said to be positive. Nasolacrimal duct is patent. So the dye which you can use is either fluorescent sodium, which will be yellowish green in color like this, or you can use methylene blue, which will be blue in color, or you can use mercurochrome, which is pink in color. Any colored dye can be used to do lacrimal test. It is a non-invasive test. It can be done by unqualified person like Daya or ward boy in the OP. So this test is mandatory before doing any cataract surgery to know the nasolacrimal duct patency. If there is any infection in the sac and if you do cataract surgery, the chances of bacterial endophthalmitis will be there. So before admitting all cases of cataract surgery, we will check the nasolacrimal duct patency by doing lacrimal test or by lacrimal syringing. So this is again the lacrimal test being done by the methylene blue dye. And here, instead of relying on patient, what you can do is you dilate the puncta and introduce the lacrimal cannula into the canali pillars and push the piston of the 2 cc syringe and push the liquid into the sac of the patient. And when the patient is lying down, patient will tell that something is coming into my throat and patient will try to swallow it. You can see the movement of the gullet or the trachea of the patient. So if lacrimal syringing is positive, then you deduce that nasolacrimal duct is patent. Okay. If there is any obstruction to the nasolacrimal duct here, what will happen? The fluid which you inject here will come down into the sac and come up again. It will be regurgitated from the upper puncta. Then the lacrimal syringing is said to be negative. So how are you going to treat chronic dacryocystitis? The treatment is surgical only. The patient is old, waiting for cataract surgery. The easiest operation is just you take the skin incision curvilinear 3 millimeters away from the medial canthus, expose the sac and remove the sac in toto. This operation is known as dacryocystectomy. But the disadvantage of this operation is you are disturbing the drainage system because when the patient is waiting for the cataract surgery, he will be 60 years and above. So no patient will complain of epiphora even after removing the sac. The secretion will dry on its own, or patient will get used to the minimal amount of the secretion which comes. The better operation is you have to break the nasal lacrimal bone and nasal bone here and make a connection between the lacrimal sac and the nasal mucosa. You cut the lacrimal sac vertically and then suture it to the nasal mucosa. You are connecting a bypass channel. When the nasolacrimal duct is obstructed here, you are opening the lacrimal sac here in the medial meatus. Natural opening of the NLD is in inferior meatus. What you are going to do is you reflect the sac and eat away the bone by the bone punch and then expose the nasal mucosa. Take a H-shape incision on the nasal mucosa and H-shape incision on the lacrimal sac and then suture the anterior flap of the lacrimal sac to the anterior flap of the nasal mucosa and create a osteotomy or new channel for the flow of the tears. It is known as external DCR, dacryocystostomy. The DCR operation can also be done by ENT surgeon through the nose by the help of endoscope. So this is the steps which shows the endonasal DCR. So you have to inject into the lacrimal sac area and then expose the bone, eat away the bone. And when you eat away the bone, you can see the bluish sac seen from the opening. And you remove the sac and do the syringing. This is the sac, and when you pass the fluid lacrimal from the sac, fluid is coming out. And daily you should do the dressing and remove the granulation tissue till fistula forms. The advantage of endonasal DCR is you won't be giving any scar on the face. You are operating from within the nose. The disadvantage is the success rate is less than 70%. So 30 to 35% of the cases will recur. The osteum will close and patient will have chronic dacryocystitis. In external DCR, the success rate is 90%, 10% failure rate